Hello everyone, I am Dr. Deepthi, Associate Professor of Pathology. So today's topic is megaloblastic anemia. Megaloblastic anemia occurs due to the deficiency of vitamin B12 and folic acid. Both vitamin B12 and folic acid are required for the synthesis of the DNA. So inadequate DNA synthesis can affect the nuclear maturation and that can affect all the cell lineages. In case of iron deficiency anemia, because iron is only the constituent of an RBC series, there will be involvement of RBC series changes only within the bone marrow or within the peripheral smear. But because DNA maturation, because DNA or the nucleus is a part of all the series, that means the RBCs, WBCs and platelets, all the three series can be equally affected in case of a megaloblastic anemia. So though we call it as anemia, patients of megaloblastic anemia on long standing can present with pancytopenia because all the three cell lineages can be involved. And vitamin B12 deficiency also causes neurological manifestations. This is a very major difference between vitamin B12 and folic acid. So there will be no neurological manifestations in folic acid deficiency, but there will be neurological manifestations associated with vitamin B12 deficiency, and that occurs because of abnormal myelin degradation. Vitamin B12 metabolism. The important sources of vitamin B12 include animal products. So these mainly are the animal proteins which contain or which are seen in the meat, in the eggs as well as within the animal dairy products. Plants and vegetables contain little cobalamin. The peptic digestion will release the dietary vitamin B12 which is bound to a salivary protein haptocorin, also called as R binder. So this protein will coat the vitamin B12 and prevents its digestion within the stomach. So once it enters into the pancreas, enters into the duodenum, the pancreas will secrete proteases, and this proteases will digest the haptocorin vitamin B12 complex and releases the vitamin B12. Now the vitamin B12 will bind with the intrinsic factor within the duodenum. But this intrinsic factor is produced from the parietal cells of the gastric fundus. But the binding will take place within the duodenum. So once this binding occurs, this complex will travel to the terminal or distal ileum, and then through the receptor cubilin, it will be taken up by the cells of the ileum and then it is absorbed. So this absorbed vitamin B12 combines with transcobalamin 2 and then it is transported to different tissues. So vitamin B12, this is the schematic representation of what we have seen now. So vitamin B12, it binds through the salivary glands which produce haptocorin or R binder protein. It binds with vitamin B12. It travels through the stomach and goes into the duodenum. Once it goes into the duodenum, the pancreas through protease will split these two apart and releases vitamin B12. This combines with the intrinsic factor within the duodenum which is produced by the parietal cells of the stomach. So this complex will be taken up by the terminal ileal cell or the distal ileum through cubilin receptors. Then the absorbed vitamin B12 combines with transcobalamin and that goes to different tissues. Causes of vitamin B12 deficiency. Strict vegetarians, chronic alcoholism, echlorhydria, where there is decreased production of HCl, and there is also antibodies produced against the parietal cells, which we call it as pernicious anemia or atrophic gastritis. Gastrectomy, where a part of the stomach or entire stomach is removed. Malabsorption syndromes, where there is a defect within the duodenum or within the ileum due to the absorption, that will affect the absorption of the vitamins. Pregnancy, where there is an increased demand for vitamin B12, and fish tapeworm, infestation with fish tapeworm, also called as Diphyllobothrium latum. So patients of vitamin B12 deficiency usually present to us with anemia, lemon yellow color tint of the skin. And why this occurs we will be seeing in the further coming slides. lemon yellow color tint of the skin, and also the neurological manifestations. And these neurological manifestations include subacute combined degeneration, predominantly involving the dorsolateral or posterolateral spinal tracts. And patients can have spasticity along with ataxia. The patients also present with glossitis, and these are all the features of vitamin B12 deficiency. Folic acid deficiency. The folic acid is also required for the DNA synthesis. Both go in hand for DNA synthesis, the folic acid and vitamin B12. There is no neurological abnormalities associated with folic acid. The important sources are fruits and vegetables, where we take the folic acid in the form of polyglutamates. So these polyglutamates, through the help of enzyme conjugase within the small intestine, it will convert it into monoglutamates, and those monoglutamates like methyl tetrahydrofolate is absorbed from the jejunum. And the important causes of folic acid deficiency include infancy, where the demand for folic acid is increased. So all the pregnant women are advised preconceptionally to take folic acid to prevent this deficiency in the infancy. Hemodialysis and use of certain drugs like methotrexate, trimethoprim or phenytoin. So coming to the metabolism involving both the folate and vitamin B12. So the folate, when it is in its methyl form, methyl tetrahydrofolate is usually it's in absorbed form. So for it to interact with the DNA or to produce, to interact with the purines and pyrimidines for the DNA synthesis, the methyl tetrahydrofolate should be converted into normal folate. So for it to be converted into the normal folate, this methyl group should be accepted by vitamin B12. So this vitamin B12 or the cobalamin will be converted into methylcobalamin, and this methylcobalamin, the methyl group is again transferred to homocysteine so that it is converted into methionine. So this is a very important step. Once this conversion takes place, then only the folate can go and participate in DNA synthesis, where it converts DUMP into DTMP, and that will result in the DNA synthesis, that is in purine and pyrimidine synthesis and their metabolism. So in this concept, the methyl group from the folate should be taken up by the vitamin B12 or cobalamin, and from it should be taken up by the homocysteine to form methionine. So whenever there is a deficiency of folate, this step will not take place. So homocysteine levels will be increased in the blood. Similarly, whenever there is deficiency of vitamin B12, again the homocysteine levels will be increased in the blood, so that there is no conversion into methionine. And there is also in this point defect in DNA synthesis. So this is one part involving both folate and vitamin B12. The similar next part involves mainly vitamin B12. In this concept, the adenosyl cobalamin will convert methyl malonyl CoA into succinyl CoA, and this succinyl CoA will go into gluconeogenesis. When there is deficiency of vitamin B12, the methyl malonyl CoA and the propionyl CoA, which is its previous substrate, both will be accumulated in the blood, and those two things will result in myelin degeneration. So methyl malonyl CoA and propionyl CoA, if both of them are accumulated in the blood, because there is no vitamin B12 or there is vitamin B12 deficiency, these will be causing neuronal myelin degeneration. Coming to the laboratory investigations, hemoglobin. Normally, the hemoglobin is decreased. That is usually presenting as anemia. MCV. MCV stands for mean corpuscular volume, that is an average RBC volume, and that is usually increased. Mean corpuscular hemoglobin, MCH, that is also the hemoglobin concentration per cell is also increased. MCHC will remain normal. This is hemoglobin concentration per group of red cells. So that usually remains relatively constant. So MCV and MCH are increased. This being megaloblastic, there is always an increase in MCV and MCH. Usually MCV will be more than 100 femtoliter. Peripheral smear, RBC, when we see all the cell lineages can be affected, so patient can present with pancytopenia. So normally in the RBCs we see macrocytic. The RBCs are large and they are macrocytic, and also macroovelocytes are seen. These macrocytes and macroovelocytes are highly characteristic of megaloblastic anemia. Macrocytic picture is the first sign of megaloblastic anemia in a smear, and presence of macroovelocytes is highly characteristic of megaloblastic anemia, which will differentiate that from other types of macrocytic anemias. Other type of macrocytic anemias can be seen in pregnancy, in hypothyroidism, in alcoholics, in those conditions, and those macrocytic anemias you can differentiate it from megaloblastic anemia if they are presence of macroovelocytes. So macroovelocytes are very important in categorizing megaloblastic anemias. Next, you can see Cabot rings. So within the RBCs, we can find 8-shaped ring, and this is because of the nuclear remnants. Similarly, Hobel-Jolly bodies, and there can be nucleated RBCs in case of a megaloblastic anemia. This occurs because there is dyserythropoiesis or ineffective erythropoiesis, because there is a lack of DNA maturation. Normally, when there is a good DNA maturation, there should not be any nuclear features or nuclear remnants within an RBC. RBC should be free of nucleus because there is a defect in the DNA maturation. So there can be some nuclear remnants which can be seen in the form of Cabot rings, Hobel-Jolly bodies, or nucleated RBCs. Next is the WBCs. This is a very important one, that is presence of hypersegmented neutrophils. That means we can have a neutrophil with more than 6 lobes, a single neutrophil with more than 6 lobes, or we can find neutrophil with more than 5 lobes that constitutes about 5%. 5% of neutrophils with more than 5 lobes. So any of this category we can take it for hypersegmented neutrophilia, and that is also characteristic for megaloblastic anemia. And platelets can remain normal. If there is a very severe deficiency, even the platelets can also be affected, and then there can be decreased platelets, which results in thrombocytopenia. So this is a picture showing peripheral smear where we can see macroovelocytes. These are the macrocytes and these are the macroovelocytes. Presence of macroovelocytes is very characteristic for megaloblastic anemia. And here we can appreciate a nucleated RBC, and these are the hypersegmented neutrophils containing more than 6 lobes within the nucleus. And sometimes we can also see teardrop cells in cases of megaloblastic anemia. Coming to the bone marrow findings, the marrow is hypercellular. In spite of pancytopenia, the marrow will try to produce more and more cells as a compensation. So most of the times, if it is a megaloblastic anemia, it will be a hypercellular marrow. And myeloid to erythroid ratio will be reversed. That means we have more of erythroid series of cells compared to other series, with increased erythropoiesis and predominantly containing megaloblasts. And these megaloblasts, the cells will appear larger in size because there is a nuclear maturation defect. So the nuclear maturation will lag behind the cytoplasmic maturation. So as the cells mature, the size of the nucleus should decrease and the size of the cytoplasm should increase. But what happens is here there is a lag. So nuclear maturation will lag behind the cytoplasmic maturation. Similarly, in the myeloid series of cells also, we can see the asynchronous development and also giant metamyelocytes. The cells will appear so large. And megakaryocyte series also shows abnormally large multilobulated nuclei. So this is a bone marrow picture where most of the cells here are hypercellular picture with erythroid hyperplasia. Predominantly we see most of the cells are erythroid series of cells. And we can appreciate that all these cells appear large, and also these are megaloblasts. The typical description of megaloblasts is they contain sea blue cytoplasm. The typical cytoplasm is sea blue color cytoplasm, and they have a large nucleus which contains sieve-like chromatin. It contains sieve-like chromatin, which is a highly characteristic feature of megaloblast cell. Coming to the other test that will help us in the diagnosis of vitamin B12 deficiency is serum bilirubin levels being increased. This is because there is defective nuclear maturation. So the cells will be dying inside the bone marrow. Some amount of cells, because of a defective nuclear maturation, will undergo apoptosis. This is called as ineffective erythropoiesis or dyserythropoiesis. So that because the cells are dying, because of that there will be raised serum bilirubin levels. So anemia along with this yellowish discoloration of the skin, together patient can present with lemon yellow color tint of the skin in case of megaloblastic anemia. Next one is serum vitamin B12 levels. Yes, definitely if it is a vitamin B12 deficiency, the levels of serum vitamin B12 will be markedly decreased along with serum folate levels if it is a folic acid deficiency. Serum homocysteine levels are increased. Yes, when either in the vitamin B12 deficiency or in the folic acid deficiency, the serum homocysteine levels will be increased because there is no vitamin B12 or folic acid for the acceptance or for the change of methyl group. So once if there is a methyl group that has to be received from the vitamin B12 for a homocysteine, so the homocysteine will not be converted into methionine and that will be remaining increased. Similarly, serum methyl malonic acid, as we have seen in the metabolism, methyl malonic acid should be converted into succinyl-CoA only in the presence of vitamin B12. So this methyl malonic acid will be accumulated in case of vitamin B12 deficiency only. So that can result, because of this accumulation, there will be peripheral neuropathy. Figlu is one of the intermediate products in folate deficiency. So that will be excessively excreted in urine in case of folic acid deficiency. Serum transcobalamin assay can tell us about the receptor status in case of vitamin B12 deficiency. And the Schilling test is done to differentiate vitamin B12 deficiency, whether it is because of megaloblastic anemia, whether it is because of vitamin B12 deficiency or intrinsic factor deficiency. So in the Schilling test, a radioactive labeled vitamin B12 is usually injected through mouth, is usually given orally through mouth, and also through the tissue an injection is also given, that is a normal vitamin B12. So what happens is, when we find this excretion, we usually see its urinary excretion in a day. So after urinary excretion, if there is more than 8% of this material which is excreted in the urine, that will tell us it is normal. That will be a normal one. But if there is intrinsic factor deficiency, there will be no excretion. And also if there is malabsorption, there will be no excretion of vitamin B12. So there will be a defect in the absorption. So to differentiate these two things, if intrinsic factor is given along with this radioactive labeled vitamin B12, and if the excretion is normal, and if there is excretion in the urine, then it is because of intrinsic factor deficiency. Even after giving the intrinsic factor, if there is no excretion, it is because of malabsorption. That is, in spite of intrinsic factor, the absorption is at a defect. So this intrinsic factor deficiency occurs because of pernicious anemia. And this pernicious anemia is an autoimmune gastritis where there is production of antibodies which will be destroying the parietal cells, so that there is a defect in the production of intrinsic factor. Usually there are three types of antibodies in this pernicious anemia. Type 3 are more important and they are more highly associated. 60 to 80% of the pernicious anemia is because of type 3 antibodies which are directed against the gastric parietal cells, and that will cause the deficiency of intrinsic factor, resulting in megaloblastic anemia. Thank you.